Hello, everyone, and welcome to the Black Health Podcast. Today's topic is exploring healthcare equity in South Africa. We're going to navigate some of the complexities of the South African healthcare system and uncover some of the root causes of the persistent structural inequities affecting access to quality care that are based on race, class, gender, and other identities. My name is Felicity, and I'm the social media manager at Black Health. I think we can just go around and everyone can introduce themselves.
Hi, I'm Paula, one of the co-founders of Black Health and the director of creative operations.
Hi, I'm Mbali. I'm the project manager of Black Health SA.
Hi, I'm Pontsho, and I'm today's guest.
Yes. So just to give you some background about our guest today, Pontsho is a journalist, editor, media lecturer, and trainer. She has a focus in health, race, and gender, and how all of these things intersect. She's also the communications manager at Soul City Institute for Social Justice and the author of Power and Faith, which is about how evangelical churches are quietly shaping our democracy. She's also a PhD candidate at Stellenbosch University, currently researching anti-obesity messaging and representations of fatness in media. Thank you so much for joining us today, Pontsho.
No, thank you. It's a pleasure to be here with all of you.
Amazing.
I know scheduling was a lot and hectic, and it's been a day, but we're really, really grateful.
We're
to
here
have you.
now.
Exactly, we're here now.
Amazing. Are you guys ready to do a quick little icebreaker?
For sure, yes, absolutely.
Okay, so our icebreaker question today is, who would you cast to play you in a movie about your own life? Should we start with our guest?
Oh my goodness. So this is a very hard question. But I would choose Wumni Musaku from
her.
Lovecraft Country. And I really love her, and just I think she's a brilliant actress. She's a British Nigerian actress, and she's really doing amazing stuff on TV, film, and I think she does theater as well. So definitely Wumni.
Yeah, no,
Incredible.
she's an amazing actress. Yeah, I like her a lot.
Okay, Mbali.
So we discussed this a bit earlier, and I was just saying to my peers that I wish I had someone a bit more serious, but I think I'm quite lighthearted and I love the energy. So I'd say Issa Rae. But as we were having this discussion, I was like, actually also like down that path, Michaela Cole. Like I think also like she has that edge that I think I'm growing into. So
That's cute. I like that. I feel like I want to change mine now. You guys said really great people. So I was thinking at first, I was like, oh, Justine Skye, because I really like her. I think she's so pretty, but I'm not sure she's a good actress. I have no idea if she can act.
She's a good singer.
Yeah,
She's a really good singer.
But so then I was like, oh, maybe Tiana Paris. She's been in They Clone Tyrone and The Marvels. Yeah, I like her a lot.
nice.
Yeah,
Okay.
yeah. So I picked Tiana Paris.
Nice.
What about you, Felicity?
This was actually a hard one for me
Yeah.
because I was saying that I feel like at face value, like I probably would choose like someone like Zoe Kravitz.
Yeah.
But then I feel like I literally have the personality of like someone who wears jorts. So like I would say like Adam Sandler. I feel like somewhere between Zoe Kravitz and the personality of Adam Sandler. I think that would get it. That would
Maybe
get
like
it.
Zoe Kravitz plays you, but the movie is written and directed by Adam Sandler.
Yes. Okay.
To just
okay.
cover your
so
bases.
the personal
Yeah.
voice really comes through.
Yeah, cool. So Paula, do you want to take us into the structure of the healthcare system?
Absolutely. Yeah, I'll start us off. So we usually like to start by like doing some level setting, just make sure we're all on the same page of our topic. And especially because like we have audiences like around the world in the US and South Africa. I think it'd be really helpful for people to know like what the South African healthcare system is before we like kind of get into like all of its problems. But so basically the South African Constitution guarantees like each citizen the right to access healthcare. And so there is free healthcare in South Africa, which is very different than the setup in the United States. I think we are still in the US like arguing for the right to have health care, but in South Africa, it actually is guaranteed in the Constitution. So there is what they call a public healthcare system, which is like free healthcare that is like funded by the government. And so that system has like 3 levels or 3 tiers to it. So it's primary healthcare facilities, which provide like immunizations, like basic services, maternal health care, what else? Oh, like TB, HIV testing is in the primary healthcare facilities. Then you have like district hospitals, which can do some minor surgeries and a little bit more advanced stuff than the primary facilities. And then you have like the tertiary hospitals and system within the public healthcare system, which can do more advanced surgeries and has specialists and things like that. And so that's in contrast kind of like to the private healthcare system. So with the private healthcare system, it's you have to pay for it either out of pocket or your medical aid. What's called medical aid here is what we know as health insurance in the US. So either your health insurance or you pay for it out of pocket. And so there's a lot of disparity in the quality of care within the two systems. So public healthcare systems are kind of characterized by like just under resourced, so understaffed. Just the facilities are sometimes dilapidated. I have a lot of experience, so I'll talk about that later. Like seeing like a lot of the clinics in the primary healthcare facilities. So whereas the private system, which I kind of use myself for like my personal care, it's pretty chill. Like it's normal. Like, you know, like for me, like coming from the States, like easy to set appointments. You know, it's like you can get the services that you need as long as you can pay for it. Whereas like the public system, which is what the vast majority of people in the country use, has a lot of quality issues. So yeah, so I'll pause there, and then I think maybe you have some stats for us about like that illuminate these disparities.
100%. I think also in South Africa there really is such a huge gap between always public and private sector. But yeah, just to speak on the stats, only 18% of our local population regularly uses private providers. Even though it's much smaller than the public sector, it accounts for about half of health expenditures. So that's like things that they spend on equipment, on staff, on all the resources that they need for that. And then about 79% of doctors work privately, leaving only 21% of doctors for the public sector. I think also, Paula, when you speak about just basically the quality of the healthcare, I think there isn't a lot of incentive for doctors, or it becomes harder to work in those environments. So I think sometimes it's understandable why people do go into private practice.
Absolutely, yeah.
There are over 120 medical schemes that historically excluded Black South Africans until 1970, and still mostly cater to wealthier demographics, which is really interesting. About 73% of white individuals are members of a medical scheme, 52% of Asian individuals, and only 10% of Black South Africans, indicating a clear racial disparity in private coverage. And again, it's something that we see where we have the Black people as the majority in South Africa, but then still a minority when it comes to private healthcare.
Yeah, and the way that you access private healthcare is through a medical scheme for most people, right? That's how you can afford it. So that statistic that only like 10% of Black people in South Africa have health insurance is really shocking. And the reason that we see these disparities, like similar to what we talk about for our U.S. audience about, you know, why we see racial disparities in healthcare access and outcomes, is due to a legacy of colonialism, and particularly in South Africa, apartheid. So, you know, we wanted to kind of talk about, like, for people who might not know, like, what was apartheid, what did it do, and kind of how did it create some of these issues that we see today in our healthcare system.
Just to give you guys a formal definition, apartheid was a former policy of segregation and political, social, and economic discrimination against the non-white majority in the Republic of South Africa. And I think what we see and how it affects us now is the fact that if there is such structural and ingrained inequity that existed before, that legacy is going to continue today. And so we are always so surprised by like how, as the majority, are we so behind, or are we pushed out of access to so many like things that we need on a day-to-day basis. But because in the past we were intentionally moved out of spaces that had infrastructure and access to those spaces, we were economically outcast and put on the side. education, all of those things now work together to create a completely different reality and situation for Black people. And I think that that's why healthcare is so hard to access, because if you've historically been left out, it's so hard to find your way back in, especially when there hasn't been active and ongoing steps to rebuild or create opportunities for us to sort of catch up or to overcome the past and what has happened before.
Yeah, no, Daves.
Yeah. And apartheid was like, it was deep. Like, you know, the what it did, like, divided people based on like their racial classification. People had to carry around passbooks that said what their race was. They weren't allowed to be in certain areas depending on, you know, what their racial classification was. They couldn't, people of the same race had to go to the same schools, live in the same neighborhoods. And it was like really mandated, like through policies and then like enforced through violence. Yeah.
There were white-only hospitals, right? Like there were hospitals where Black people actually couldn't get treatment because they were Black. And then you find, you know, what we see today, where there's overcrowding in hospitals. That's a legacy of apartheid, because back during apartheid, hospitals were always overcrowded because they were not adequately staffed. There were not enough Black doctors to staff those hospitals, and white doctors could choose to work there or not to work there. And that's why we have even a class of nurses, because a lot of the times a lot of Black women or Black people were allowed to be nurses during apartheid.
Yeah, that's true. I think also that's why a lot of South Africans are of the belief that like apartheid kind of works, and I think that that's what makes it a little bit more sinister and calculated. Is that although it's over, it's still such a struggle for us to be able to just have access to things that should be normal or things that our counterparts have access to. So I think that is actually quite scary.
And something that's just coming to mind now as we talk about it is, what is the impact of medical racism, or how we understand it now? Is it because of the treatment we were exposed to before, that now it's an ingrained culture and understanding that we believe our voice is not important, or there's someone else who needs to tell us about our health as opposed to us feeling confident to express those needs? I don't know what you guys think about that. Like, why do you think it still frames itself the way it does? Because I think that although, like you were saying, you use private healthcare providers, I do too, but there's still that element of like, if I'm expressing myself and like, you know, when your body, like if something's wrong, but I still find that if you try to express yourself in that way, there's still an element of you don't know what you're talking about, or someone who could tell you about your body or your health rights or what's going on. I don't know.
I think that's how like racism operates, right? It says like, you don't have to listen to the voices of Black people. We don't know what we're talking about. And just, yeah, like you said, like that whole legacy of like medical racism, of like, just that, you know, like we're stupid and that we need to be dictated about our health because we can't make the right decisions for ourselves. I think that comes up a lot like in HIV work, which is like a field that I'm familiar with. And obviously it's a big thing here in South Africa. And just the idea of like why it is that like HIV is as prevalent as it is. And I think a lot of times the common thinking, this is even amongst like Black people that I talk to, is that like Black people are more promiscuous than other racial groups. And that's why our HIV rates are so much higher. And then Black South Africans are more promiscuous than anybody else. And that's why the problem is the way it is here. And that's just like not true. Like the research just shows that actually Black people have a lot of healthier and safer sexual behaviors than other groups. It's really the inequality that we are facing that is causing HIV to be running rampant in our communities, which I'll talk about in a little bit.
And that's the colonial project, right? Like science and biomedical science in particular has been used to uphold the colonial project and to entrench or embed coloniality in everyday experiences. This idea that Black people are more promiscuous is based on 16th and 17th century ideas of Black men, particularly as these savages that have insatiable sexual appetites. It's linked to the idea that Black men were raping white women left, right, and center, or or even the idea of when you think about Sarki Bartman and what Professor Yvette Abrahams calls the genital encounter that happened on how her body was sexualized, even though that's just how her body looked. And so our bodies as Black people have been demonized, have been sexualized, and we find that these ideas of scientific and medical racism are still entrenched in the health system right now, where if a Black woman goes into a doctor's office, even if the doctor is Black, there's this idea of not listening to her. You know, there's been this big case in South Africa right now around the forced sterilization of Black women living with HIV, where there's a group of Black women who took it to the Commission of Gender Equity that they were sterilized against their will or without their consent because they were HIV positive. And that is a violation that is deeply entrenched within coloniality and the idea that Black women don't have the agency to make decisions about their bodies, which at the root of it is about the fact that Black women are seen as less than, and that results in their bodies and them as us as a whole being treated as less than.
I think that also speaks to like the huge power dynamic that obviously exists, especially in the doctor's office. But one thing that I think that I've been privy to or like have learned a lot about having worked with Black Health is just being more proactive at the doctor and remembering that you can actually ask the doctor questions. I feel like I always am like a bit nervous. I'm like, well, this person has a PhD, they've studied, that's the doctor. But again, oftentimes already they might have some biases or prejudices. I think also we've spoken about like pain tolerance and how there's this belief that like Black women are so much stronger and we don't need like all of the drugs, especially I know with child labor can be a really bad thing. But I think also to have the to be able to listen to your body is really important, and then to be able to go in and ask questions. I think at the end of a doctor session, I'm always like, when they're like, do you have any questions? I'm always like, no, but it's like you actually need to go in there and ask them and really ask them. I think that that's one of the ways that you can empower yourself in that situation.
But patient advocacy is easier in private healthcare than it is in public healthcare, right? We're talking about the overcrowding of hospitals or hospitals that have one doctor or clinics even where people are corralled almost like cattle in the facilities. And even if they're not being mistreated, you have only such a limited time with the doctor. Like, for instance, I'll always talk about Black women more because I'm a Black woman and that's kind of like my focus area in general. But like when Black women, and I say Black women because those are the women who use the public healthcare system. When women, particularly young women and adults and girls, go for contraceptives in clinics, there's just like they're called and they're given out contraceptives or the injections or the implants almost in a line. And where sometimes they don't have an opportunity to ask about their options. Like, what if I go on the pill? How's it going to treat me? What is the side effects? What if I go, or whether or not their ideas of, I don't ever want to fall pregnant, so should I go for sterilization, or should I be on an injectable contraceptive because that's more long term? So those structures have been built and they're a legacy of the inequalities that exist. As you mentioned, Felicity, our healthcare system has been racialized because our inequality is racialized, right? We have a racialized class system, a racialized gender system, and it's very hard to not see the project of coloniality in the way in which our healthcare is structured.
No, that was a great point. Like when you said like Black women are the ones who use the public healthcare system, it just reminded me of like the job that I used to work that actually brought me out to South Africa. I was helping to manage like a national HIV program. And one of the things I would often do were to go to the primary care facilities, these clinics. And I would go with like my colleagues a lot of times. And so I was with one of my white colleagues. They're white South African. And so as we were leaving, we would go out about a lot, but as we were leaving like this one clinic that was in a township, I just brought up to her, I was like kind of like asking her like, you know, what is your experience in South Africa, your experience of apartheid and how things are today? And mind you, like me and this colleague, like we still to this day have a good rapport, but like people are sometimes just blinded by their privilege, right? And so, you know, so like she's saying to me, she's like, you know, obviously, like, you know, apartheid was horrible, but it's over now. And yeah, yeah, it's over. And now, you know, Black and white people can live together and things are good. It's much better. And we're driving, like we're leaving the clinic that we were just at. Everyone in that clinic was Black. It's in a township. Everyone we're driving past in the broken roads with the potholes and the, like, you know, the houses that, you know, are like almost informal structures. Like, everyone here is Black. So when we drive back to our office and everyone in our office is white and we're in Pretoria and things like that, you know, it's like apartheid is very much still alive. Like we can see it. We're driving past it. We're driving through it. We're apart, you know, we're in this system. And like all the clinics I would go to, like we would, like I said, it was a national program. So we would be all across the country. Every patient in there was Black. It wasn't until we kind of went to KZN that I started to see some Indian people in the clinics. But everywhere else we went, it was Black people. So I'm like, it's Black South Africans who have to use the public healthcare system. Like they don't have an option, you know? But yeah, that brings me to my next point of just how like there's this topic of intersectionality that we want to touch on, and how race, gender, class are so intertwined and overlap in the healthcare and the access to healthcare that people get here in South Africa. So like I mentioned before, you really see this a lot like with HIV. So HIV is basically the biggest risk factor for HIV is poverty. And poverty is you're much more at risk of living in poverty if you're in a single female-led household here in South Africa. And so I just wanted to kind of talk through with all of you like this intersection that we see, like what does that mean? Why is that race and gender are so connected here in access to healthcare and those health resources?
Yeah, you know, when we think about particularly HIV, South Africa has the largest HIV treatment program in the world, and we're one of the highest HIV people living. We have the highest population of people living with HIV, or one of the highest in the world. And I think a lot of times when we think about and when we think about women or who is most affected or infected with HIV, Black adolescent girls, Black women are often seen as the key populations, which is a word I have a big problem with, because it kind of pathologizes certain groups of people. But that is the truth. However, I think when we look at HIV, a lot of the times we don't look at the social determinants of health. Beyond just the gendered nature of HIV, we don't look at the fact that when people live in an unequal society such as South Africa, that is what makes them more at risk. And when people don't have the opportunities to be in a healthcare system where prevention or preventative methods are easy to access, that's how we find that certain kinds of illnesses, non-communicable and communicable diseases are often seen in these ways. And so it is racialized, it is gendered, and I would even think it's about class and where you sit in the grand scheme of the LSM.
I also think that the gender care economy comes into play here, because I think in South Africa we see disproportionately Black youth or Black young women having to not go to school, having to not have a job or a livelihood to stay home and to support a family or to take care of either their siblings or their peers. And I feel like that also plays in, again, when we're talking about intersectionality, like you don't have that access to education that can inform you or take you beyond your circumstance and like propel you into a new reality. But then also being at home in a township, we know the rates of gender-based violence, we know all of these things. So I feel like all of it is perpetuated by that the intersections of gender and race. Like I feel like Black young women specifically are just so badly placed to be able to break the cycle because opportunities are genuinely and like constantly taken away from them. And if it's taken away at such a young age, to be able to break out of the cycle, we know is nearly impossible. So I think that that also will affect the way that health is then affected, especially based on violence.
I actually recently watched a podcast. I think it had Oprah and Michelle Obama, and they were also speaking about how obviously we call it informally in South Africa black tax, which is what you're referring to, which is when obviously you have to either look after your family because not everyone is going to be given the opportunities or the place that you've been given. And Oprah was just speaking about how sometimes she has to kind of you know how she has her school and she has to talk her students out of sometimes when you get an opportunity, maybe you're the first to go to university, your scholarship is covered. A lot of those students obviously still feel pressured to maybe now they're using the money that they're supposed to get for school groceries to send back home for someone else that needs it. So even in getting those opportunities, you're still disadvantaged, or you're still trying to, look back and care for those that haven't had the opportunity. So I think that also makes it hard because even if you're given the platform, how well can you actually use it to leverage yourself?
That's to me part of the case for reparations, because it's like we're having to pay back, the things that were stolen from us, whereas like that shouldn't be our responsibility. The resources are there and they should be made available to us.
Yeah.
But what do you guys think about the fact that, again, it seems we keep coming back to this point around how Black women are most impacted by the healthcare system. And obviously they are a minority and there are other minorities that are also impacted by the health system. What does it look like? What do reparations that bring health equity look like, in your opinion?
I think that's an excellent question. And I feel like I don't have the answer. And I think the answer kind of lies within those communities who are most affected. And so there's this concept within critical race theory about centering in the margins. And so we go to those people, the Black women, the Black disabled women, the Black trans women, the people who have like multiple intersecting identities that, lead to these very deep oppressions and situations. And we ask them, what does it look like for them? I think that would be a good first step to try to like find a lot of those answers. But yeah, I feel like they're definitely like in the whole entire concept of anti-racism, it's about doing something, it's an action. It's not just being colorblind or like, it's fine now. It's about redressing the harm that was already done. And so that definitely needs to be done.
Pontsho, I have a question for you. Sure. You write a lot about the intersections of marginalized identities and health. So I wanted to ask you, what do you find the most pressing or recurring issue in the healthcare system for people living at these various intersections?
Honestly, and it's a biased opinion anyway, sexual reproductive health and rights. I think we take it for granted how access to sexual reproductive health care is so limited due to many issues, but also because of how Black women are socialized or taken in society. We talk about, for instance, right now in South Africa, everyone's going crazy about the Depaverin ring, which is the silicone ring that you insert inside your vagina to prevent HIV, and you change it every month. And everyone is like, yay, new methods of HIV prevention for young women and women in general. And this is seen as a good thing. But how do you expect women who were socialized to hate their vaginas or to not embrace their sexuality to go from, as a young girl, if you sit with your legs apart, it's seen as a bad thing, to now inserting a whole silicone ring inside your vagina? When do you get comfortable with your vagina at that much? Where is the comprehensive sexuality education that's happening in schools that enables the comfort or the destigmatization of your genitals and your sexual reproductive organs? So it's like we have these great biomedical interventions for real life health inequalities that exist, but they're not done at the same speed as the social destigmatizing, the social reparations that have to happen, particularly when it comes to Black women. So I think something as simple as that is a big issue. And I think when we think about the ways in which a lot of people are anti-abortion in South Africa, we have one of the most liberal abortion laws in the world. Our Choice of Termination of Pregnancy Act, allows for the termination of pregnancy from anyone from the age of 12 within the first 12 weeks of pregnancy. And a lot of people, due to religious reasons, due to the fact that people find the idea of having sex as a teen scandalizing or immoral, we have where young people or anyone goes into a facility seeking to terminate a pregnancy and they're turned back. They're turned back. We find rural areas that don't have access to termination of pregnancy services, just like we have in the urban areas, and people have to go into private sector. It costs thousands of rands to terminate a pregnancy in private sector, but we don't see the public sector make it more accessible or campaigns around educating people about the Choice of Termination of Pregnancy Act and why it started. The reason it started is because the maternal death rates in South Africa were so high, particularly amongst Black women, because if you can't stop terminations of pregnancy or abortions, you can only stop safe ones, right? So people were still trying to terminate pregnancies, even though under apartheid it was very hard or there was a restrictive law against it. So these ideas are something that keep me up at night, to be quite honest, around what happens to a young woman or anybody who is in a rural area. What happens to a trans man who is, God forbid, raped and falls pregnant and they're trying to access termination of pregnancy? These are the things that we don't think about. And nurses and healthcare providers also have the idea that it's a sin or they're morally against this, and they can conscientiously object around giving these, but they don't have the responsibility to refer patients to people who are willing to get these services. So it's intersectional why access to termination of pregnancy is so rare in South Africa, or is so hard in many places to access it. And these are the things, really. Sexual reproductive health brings so much bodily autonomy. It makes or breaks the future of many people. And if we are not able to access it as women, our futures are literally on the line.
Yeah, I think what you're saying about like the culture around it, like it's one thing to have the law or to have the access, but what about the culture and the stigma? And that's something, if you haven't watched our last podcast episode, you should definitely go check it out. But we spoke a lot about how despite having access, there's the stigma or shame placed on women for expressing sexuality in any way. So whether it's positive of like, I'm a person who enjoys having sex, or if it's from a healthcare perspective of, hey, something's wrong with my body. Maybe I've had a sexual experience and I'm worried about what's happened, but now there's the shame because I've had the sexual experience. And if I go there, are they going to shame me for having sex? If I'm a young person, are they going to shame me for having unprotected sex? It's just like the culture around it is so bad that no matter what access we have, people won't uptake that access, because what's the point if you know that you're gonna get turned away? Or I think most of us have even experienced it in one shape or form, even in the private sector. If you're trying to get something like a morning after pill or contraceptive, the shame and the judgment, and it's like, but I'm doing the proactive and good thing. Like I've taken the time to do my research, and I'm doing what I think is right, but still you can see the person that you're dealing with isn't ready to meet you on that level, maybe from an age perspective, a culture perspective, and it's hard to be met, like you said, with people who won't say, I'm not doing it, but if you go to this place, they'll help you, you know, like and then if you're somebody who only has that one lead or that one place that you know, once you've gone there and you feel like you were rejected or you didn't get what you needed, you give up. You don't know where to turn to, where it's going to be affirming healthcare, which is crazy. But taking it a bit further, what challenges do you think refugees and non-SA citizens and migrants face when it comes to accessing healthcare in the country?
Oh my word, this is such a big issue, and particularly because South Africa is so xenophobic. I think particularly, actually, we're very Afrophobic, right? There is a certain disdain for African migrants and refugees that is not there for other kinds of migrants or expats, as we would call it. And again, I don't know how many headlines we've seen where migrant women are giving birth in the streets, literally on the streets, because they've been denied healthcare services. I don't know how many times, when I was a journalist, I remember writing a story, or editing a story rather, from one of the journalists that I worked with, where they were making migrant women pay for the antenatal care book that you get at birth. It's absolutely free in any public institution, but the nurses did not want the migrant women and their literally brand new babies to access healthcare. So they had to, for their babies to be registered or to even be able to come for the immunization shots, they had to pay, I think at the time it was about 490 rands, if I remember correctly. That's a lot of money. That's a lot of money. There's issues around language barrier, where you find a lot of migrant women don't necessarily speak the language, or not just migrant women, migrant people don't really speak the language. And then there's a barrier in accessing healthcare that is up to the standard that it requires to be, or where a patient is unable to really express what is wrong with them. So even though South Africa is signed on to different international laws and policies that guarantee migrant and refugees access to healthcare, in practicality, because of our Afrophobia, we're not seeing it happen. And it's a travesty, because another thing that happens is that migrants and refugees become scapegoats for our ailing public health system. I don't know how much research has been published that shows that migrants do not overload our public health system, as our government has said, as people believe in the streets. However, that's what people believe. And a lot of times, Afrophobic sentiment is couched in those ideas around, no, our public health system is a mess because migrants and refugees are using our public health system. It's a myth. There's so much research that shows that, but it is so ingrained in our society, and they really, again, they're in the margins and they bear the brunt of the unequal healthcare system that we have in South Africa.
I think what keeps coming up is also these social and psychological things that are kind of underneath everything. And I kind of feel like that's why I guess the degree works or the practice works if you're a nurse, but I think that there's even when we talk about solutions, I feel like there's a degree of maybe even sensitivity training that needs to happen. There's a huge emotional aspect, because I think even what you're speaking about with the Afrophobia, or with people maybe not even being able to speak the same language as you, there's a person that you can work with who maybe wants to understand what you're saying, so we'll try out a whole host of things to try, maybe we'll arrive at the same conclusion. But there's also a person who maybe is Afrophobic xenophobic and doesn't care to meet you halfway with that communication. So if there's that level of bias already, again, how are we going to get anywhere?
True.
Yeah. No, I was reading an article that said that there's like only about 3% of people in South Africa are foreigners. And so like like they think like the same, numbers could be applied to the healthcare system of how many foreigners are utilizing the healthcare system. And then it was even saying there's probably even less because a lot of times particularly like migrants and refugees usually tend to be a bit healthier because they had to be healthy to be able to move. Yeah, to make that move. So you actually get like a bias towards healthier people like coming into the country. So as you said, Pontsho, like it's a myth. It's a complete myth, like about that, and they're being used as scapegoats for the problems that are happening. But people are really buying into it because I've seen a lot of like news and just things on social media just about this issue and people being very Afrophobic in their sentiments. Yeah. And I wanted to, Pontsho, you brought up earlier this topic around like just different differential care like in rural areas. And so I wanted to kind of talk a little bit about like what is life like in rural areas in South Africa and how that affects access to healthcare, and also like in townships and just kind of like why Black people live in townships, why Black people live in rural areas. We know it's apartheid, but like kind of talking through that a little bit and like just what does that look like today for people who live in those areas? Yeah.
It's still quite prevalent. You find, if we're talking healthcare, that the healthcare in rural areas is not the same as in urban areas or what they call peri-urban areas, which are like semi-rural, semi-urban settings, right? And a lot of access to particularly tertiary health institutions or facilities is harder in rural areas because of the hospital is too far, or there are too many rural areas that are far apart, and there's no way of centralizing the tertiary health care. So I think there's still a lot of issues around particularly rural areas. I'm from a rural area and I'm so grateful that my parents have medical aid because, from experiences in our community that talk to rural healthcare and how dire it can be, it really matters to me, or I'm really grateful that we have the privilege of having medical aid where we can buy ourselves out of public health care. But I remember again when I was a journalist and I focused on health, there were stories of, women waiting so long to get tested for breast cancer that their breast cancer would advance to later stages. In fact, in 2018 or 18, when the Northwest Province's healthcare system or the healthcare portfolio was put under administration by the National Department of Health. I went there to cover what was actually happening and how particularly people in rural areas were impacted by it. And I remember seeing, literally, I wrote a story about a woman who was being transported in a wheelbarrow home as the hospital was closing down due to the protests that were happening for the province being put under administration. And she later died, a few months later. Her name was Ntombizodwa. Ntombizodwa died because 2 years prior to that, she actually went to the hospital. She felt the lump in her breast. She wanted to get it treated, but it never got treated. And then the breast cancer spread so much that she eventually succumbed to the disease, to the cancer. And this is somebody who tried, but there were no oncologists in the province at the time, or she just couldn't get an appointment and it ended in her death. So rural areas are really affected, and as well as township areas. Again, the class differences really play a part in all of that.
I remember one time I was doing clinic visits in Eastern Cape, and we were in quite a rural part of Eastern Cape. And we drove like an hour. We were driving like multiple hours to get to this clinic. And like an hour into the drive, the road was just broken. Like there was just no more road. I think there had been maybe a flood recently, and it was just like, and we ended up, we could even do the visit that day. We had to turn around. And the whole time I was talking to my colleague as we were driving back, I was just like, what are the people doing? You know, like the people who need to access that clinic, what are they doing today and this week and this month, however long it takes to fix this road? So, yeah, big issues. But yeah, just to go into like kind of our last piece for today, we like to try to end off on a bit of more positive note. So, and just be hopeful. That's like the work I feel like we're all doing. And so we want to talk a bit about like what is in the future for the South African healthcare system. And I wanted to ask you, Pontsho, like what activism are you aware of to help improve health equity in South Africa, and like what is the government doing? I know there's some things with national health insurance and things like that, so I just wanted to know what you know about that since you're so deep in this space.
I mean, right now it's election year. It's an election year in South Africa, and we're seeing that the National Health Insurance Bill has been passed in Parliament. And that's a big step, right, to having universal health care. And in my opinion, there's a lot of things that can still be improved by in the NHI bill to ensure it runs smoothly. There are concerns around a governing party, the ANC, and with the rampant corruption in the party and in government, whether it will be able to be implemented. But as you said in the beginning, or as Felicity said, 82% of South Africans use the public health system. So I think the NHI is long overdue. And I personally, and I know a lot of activists are willing to sacrifice their comforts of a private healthcare system for the benefit where primary healthcare is taken seriously, where there is a level of dismantling of the exploitative private healthcare system. So I think a lot of work in terms of trying to improve the NHI bill that a lot of advocacy and activist groups have been talking about, trying to make it more intersectional and talking about how it affects or can impact or what changes need to happen in the bill so that people with disabilities are better represented in there, how reproductive health is better represented in the bill, how all of these things that really affect people who are marginalized are really represented in the bill. And I think there's a lot of sexual reproductive health activism again as well. You know, there have been so many threats to our, for instance, choice of termination of pregnancy bill, but there's been a lot of activism around trying to protect it and ensuring that our abortion laws remain as liberal as they are. So there's a lot of even health equity in rural areas as we're speaking. The organizations such as the Rural Doctors Association of South Africa, RUDASA, that works in rural areas and really works to improve the rural healthcare system. It's dedicated to that, and its doctors and other healthcare professionals, as well as epidemiologists and other kind of experts within the healthcare system, really working towards making rural healthcare more equitable. So I think there's a lot of good that's happening in South Africa, and I think our policies are great on paper, but we have a problem with implementation.
Yeah. Yeah, as a US citizen, I am absolutely rooting for you all on the abortion fight because we are struggling down bad. So yeah, keep fighting while you have it. And yeah.
Thank you, Pontsho, for just taking the time to be here with us today. I think that we can all agree that the knowledge is extensive, and you had so much benefit and value to add to this conversation. And I've learned a lot, so I'm sure our audience will definitely echo the same sentiments. So thank you so much for being here today.
No, thank you so much to Black Health for having these conversations. It's particularly really great to see young people have these conversations, and the Global North, Global South partnership that Black Health is really promoting and actively involved in is something that I think we need to see more of this. And yeah, I love your work, and it was a pleasure to be here.
Thank you. And is there anything or any upcoming projects or work that you have coming up that you can share with our audience so that we can follow you and follow the work that you're doing?
Actually, yeah, I like you mean Felicity mentioned in the beginning. I'm launching this month. I'm launching my book, Power and Faith: How Evangelical Churches are quietly shaping our democracy. And in fact, I think it's a health book to a large degree because I deal with how the ties between the U.S. evangelical right and South Africa's evangelical right are impacting on access to sexual reproductive health, how how evangelical churches are fighting the decriminalization of sex work, how they're fighting comprehensive sexuality education in schools. So I think the book is quite relevant to this topic. I'm also doing my PhD focusing on anti-obesity messaging, particularly in concern to the health, wellness, and happiness of Black women. So that's kind of the next step, trying to get this PhD.
Awesome. And how can we follow you or get access to your work? Do you have any social media handles or website or anything?
So I'm on Twitter and TikTok on Pontsho_Pilane, where I actually really talk about these issues and how they kind of manifest in South Africa. And yeah, you can find me there. I've recently put my website down to focus on my PhD because the content generation takes up the time. But yeah, that's where you can find me. Twitter, or rather X. And X and TikTok.
Okay, awesome. Thank you so much. And thank you to the Black Health team for another amazing conversation. Thank you to you, everyone, for watching this episode of our podcast. Be sure to like, subscribe, follow us, and to share the message with your friends. Please also comment in the sections. Tell us what you think. Tell us what you want to hear from us in the future. And thank you.
Thanks. Bye.
Bye.